Yeah. You got it that time.
Yeah. So we're just going to do a half hour or 25 minutes or so on growth hormone disorders. What is growth hormone?
The hormone that makes you grow.
Yeah, exactly. So is it stable in quantity across all cats? Like is the sort of normal range for cats quite narrow?
That I don't know.
I've asked the question really poorly. So, okay, let's talk about dogs that range in size from 2 kilos up to 70 or 80. Is growth hormone different in different size dogs?
Again,
No. I would have thought maybe yes.
Yes, it is. Yeah. And it's not very clinically significant. Do we measure growth hormone levels?
It's very hard, I think, because it's like it's only released intermittently. So it's like if it's low, it doesn't mean it's actually low. It could just not have been released at that time. Yes,
exactly. So it's released in a pulsatile way. So where you might happen to catch it on a downswing and make a false diagnosis of hyposomatotropism, for example, or you might catch it on an upswing and call it normal when actually it was low most of the time. So it's very hard to get an average. How do we measure? What's the sort of surrogate test that we can do for growth hormone levels?
Insulin growth factor. Insulin growth-like factor.
Insulin-like growth factor. Yeah, there's a like in there somewhere.
Growth-like.
Growth.
Like growth, yeah.
Insulin-like growth factor. So insulin-like growth factor is you know how fructosamine is a 2-week average of glucose? Insulin-like growth factor is a 24 average of growth hormone. So it gives you a relative level. So if we were looking for hypersomatotropism in a dog, would we be able to just look at insulin-like growth factor with one reference range? Or would we need to have different reference ranges for different size dogs?
I suspect it's the latter, but I don't know.
Yeah, it's the latter. Fortunately, it doesn't happen very often in dogs. But let's start there because it's the rarest and most exciting. And obviously we all like zebras because they're medicine people. What would the pathogenesis of hypersomatotropism be in dogs?
Probably a pituitary tumour, I would think.
Yeah, that's one of them. There's another one.
No, you've got me again.
It's a good one. I'd forgotten about this until I read back on my notes. Prolonged progesterone exposure can cause mammary growth hormone production. So dogs that have had prolonged progesterone exposure, like in the luteal phase of estrus, will have increased growth hormone levels and sometimes develop glucose sensitivity in that time, so sort of pre-diabetes as a result of the influence of growth hormone. So mammary tissue has the capacity to produce growth hormone as well. In humans, they've documented a whole heap of carcinomas which produce growth hormones, so bronchial, endometrial, and mammary, I think. And they can all produce excess growth hormone, but that's not been documented in dogs, but it's on my radar. So if we ever have a dog with signs of hypersomatotropism and maybe a bronchial tumour that we could analyse insulin-like growth factor. It's a cool zebra. So let's talk about cats because they get hypersomatotropism more. What's the pathogenesis or etiopathogenesis of hypersomatotropism in cats?
So, dear idea, I should have read this up. Because I saw one during the week that has had its pituitary removed, its sash.
Yes. Why would they remove its pituitary?
Oh, it must have been producing too much growth hormone.
Good. Yeah. Why would it do that?
That it would suggest a tumor, I think.
Yes, exactly. Yeah. So an adenoma usually, so normally a benign tumor, but a tumor nonetheless, producing of the, somatotropic cells in the pituitary gland. And interestingly, there was a paper by Melora Sharman, who's a medicine specialist who works in England now, but is Australian. And she's found that these tumours are often plurihormonal. So there's more than one hormone being produced. So they arise from the growth hormone cells, but they can sometimes produce ACTH and TSH as well. No, sorry, prolactin as well. We've got a little tumour producing too much growth hormone. What impact does that have on the cats? What do we actually see clinically, and why would we be looking for hypersomatotropism?
Well, they become diabetic.
Yes. Yeah, exactly. Why?
Because growth hormone is one of the glucose, shall we say, producing hormone, one of the 4 glucose producing hormones.
Yeah. Gluconeogenic hormones?
Counter-regulatory.
Yes. Yeah. Excellent. So it's one of the sort of counter-regulatory hormones for glucose homeostasis. It's anti-insulin in that it decreases glucose uptake or insulin sensitivity peripherally, resulting in a higher blood glucose level. So we'll get insulin resistance and then a higher blood glucose level. And then what would the islet cells be doing in the pancreas when you've got persistent hypoglycemia?
I guess they become exhausted.
Good, excellent, exactly. So then we end up with hypoinsulinemia eventually because of beta cell exhaustion. Excellent. So why do we see this more commonly in cats than dogs?
No idea.
So cats are more sensitive to insulin resistance. They get more of that sort of type 2 diabetes, don't they?
Oh, yes.
Yeah. Yeah. And then their beta cells get exhausted. They're very, very sensitive. They get exhausted pretty easily. So this manifests almost exclusively as diabetes. We don't really see acromegaly in the absence of diabetes. So if you don't have a diabetic cat, no point testing for it. In which cats, what clinical signs might you've got a diabetic cat, you're finding it hard to control. What clinical signs might make you think, oh, this cat might have acromegaly?
They get like disproportionate body parts generally. Yeah. So they get like gaps within their teeth and
yes.
bigger face. I think bigger paws as well.
Yeah.
Something to do with their long bones as well, I think. Can't remember.
I don't know about long bone. I love the word. Oh, you're right. A degenerative arthropathy.
Oh, that's probably what I'm thinking. Something along those lines. Yeah.
Yeah. The word for the big jaw is prognathia inferior. Prognathia. Yeah. I really like that one. So externally, that's what we'd see. What organs are most affected internally by this growth hormone excess?
The kidneys.
Yeah.
They get bigger.
Yeah.
And the liver, I imagine, would be bigger as well.
Yes. Well, unfortunately difficult because we're dealing with diabetes as well. So we get to see fat storage in the liver. But yes, the liver might be big. Any others?
Oh, probably the pancreas, I guess, because it's no, it wouldn't be the pancreas.
Good thinking. The pancreas, because so less than 5% of the pancreatic tissue is endocrine. The actual bulk of the pancreas probably won't change too much.
Right.
But where I was heading with that is the trophic effects of growth hormone impact the heart quite a lot. It's one of the differentials for which common heart disease.
Oh, it'd be hypertrophic cardiomyopathy.
Good, excellent. So new heart murmur might be another clinical sign that you hear on your physical exam if they're developing hypertrophic cardiomyopathy. So in light of the fact that we're looking for a diabetic cat, what might we see on our bloods in these patients?
What was that question? Sorry.
What might we see on blood tests in these patients? So we sort of know what to look for with diabetic cats, and we'll go into that when we do diabetes. But are there any markers on hematology specifically that might indicate acromegaly is present? Take a guess.
Well, would you get polycythemia?
Good, excellent. Yeah, they can have an erythrocytosis and the other one?
Thrombocytosis?
Leukocytosis. Yes, not thrombocytosis, but I think that's probably because cat platelets just all stick together and you never get an accurate count anyway. So I'm sure they've got thrombocytosis too. So that can just be a little hint if you're doing a diabetic cat. Normally they wouldn't be polycythemic, but if you've got a high red blood cell count, maybe worth doing insulin-like growth factor. I just gave it away. How are you going to diagnose it?
Yeah, insulin-like growth factor.
Yeah, excellent. So have you ever diagnosed one?
No, but I saw this one during the week that says pituitary removed, and it cured its diabetes.
Mm.
And it's also, it's on Cortate, and it's on desmopressin, the monthly one, whichever that is. Very expensive, the man said. And thyroid hormone.
Mm. The thing is probably the monthly one's probably the DOCP, the mineralocorticoid.
That's it.
Yeah, it's quite a lot of meds, isn't it?
Yes. The owner was not impressed with the cost of the DOCP.
Sure, he wasn't with the cost of hypophysectomy either.
Yeah.
Yeah. Yeah, it's an expensive exercise. But the IGF-1 levels typically, so the normal range is like something like 200 to 400 or something like that. And with acromegaly, it's usually over 1,000. There's a bit of a trick though. If you're dealing with a newly diagnosed diabetic who's completely out of control, insulin deficiency decreases growth hormone. Sorry, I'm getting a bit physiology on you, but insulin deficiency, which happens with beta cell exhaustion, will decrease the growth hormone receptors on the liver. So the excess growth hormone can't then trigger IGF-1 production in the liver in uncontrolled diabetics. So if you're testing, if you see a diabetic and you think this cat's got acromegaly for sure, I'm never going to get on top of this diabetes unless we deal with that, you actually have to try and control it, or at least get some controlled supplement insulin to reverse that change in the liver to actually be able to diagnose insulin growth hormone excess. Does that make sense?
I'm sort of wondering.
Yeah, that's really cool. I didn't
Need to know that, but it's in some ways it's counterintuitive, because where the glucose drops, actually you would usually drop with too much insulin, wouldn't it? Yeah. So yeah, another. Yeah. So too much insulin wouldn't be creating the receptor problem. That'd be the opposite.
Yeah, exactly. So we want to supplement insulin, get those growth hormone receptors back on the liver, and then test for acromegaly a month or two into our treatment. So I think that when I say a month or two, it actually is documented 6 weeks after starting, but I don't know why. But that's the sort of time frame that you're looking at. But yeah, if your clinical signs are suspicious, then I would certainly put it on the owner's radar that they've got another very expensive test coming up. Not that expensive.
Would MRI be a benefit?
Good question. Yes, yeah, you can see these on MRI. What was the comment in the note in my notes? They're tiny weeny, and I think CT was almost as good as MRI because of the contrast enhancement. They get a big sort of flash, a pituitary sort of flare, I think they call it, on CT. But obviously you'd have to have a very high quality CT and good image acquisition protocols and stuff to see it. I'm not sure if it's arterial phase or not. But yes, imaging is helpful, but it's not diagnostic because you could have a tumour producing ACTH or and prolactin producing one potentially. So what treatment options do we have?
Well, hypophysectomy is obviously one of them.
Yeah,
Which,
and that's by far best outcome as far as disease management.
You can do radiation, but it's poor. It's not very. It's kind of hit and miss, is what I remember reading.
Yeah, because they're so tiny, so very small. Yeah. Any medical management other than the diabetes management?
I think there's like a half paragraph in it on something, but it's not very good.
It's not very good, not very viable, and so the somatostatin analogues.
That's right. Yeah. Can you get them in Australia?
I think you can, but I think they're super expensive, and they're like you've got to use them as a CRI and stuff. Like they're made for people with infusion pumps and stuff like that. So they're not. There's no practical medical option for managing acromegaly. We've talked about dogs. Let's talk about hyposomatotropism in our last 6 minutes.
That's cool.
It's cool. Have you seen it?
No, but we saw I did see a dwarf once. That was it was a hypothyroidism, congenital hypothyroidism. So it wasn't hyposomatotropism. That was cool.
So that's an interesting point. So what are the differentials, endocrine differentials for growth disorder? Like poor growth. What's the word?
You mean like whether it's like a hypothyroidism versus a hyposomatotropism?
Yes. Yeah.
Do you mean like so hyposomatotropism you get a proportionate dwarfism, and in hypothyroidism you get a disproportionate?
Yes,
dwarfism?
exactly. Yeah. Can you explain what that means?
So proportionate means that just all the body parts haven't grown, so everything's kind of stunted in a way. But then disproportionate is more when you get some parts that have grown normally. So I think in that case they've kind of got like a big head and big tongue. They have really stunted legs, but I think small eyes I think as well.
Yeah.
I think just weird stuff like that.
Yeah. So I'm just going to repeat that just in case the sound quality didn't work on the recording. But the main endocrine differentials for poor growth, and I'm going to throw an extra in on top of what Josh said, but hypothyroidism, which can be congenital, or hyposomatotropism, which is most commonly congenital as well. So both of these manifest pretty early in life. Within the first 6 months, they'd start to see some differences between litter mates, size, coat quality, growth, and things. And the other one I'm going to put in there is excess glucocorticoids, which is most commonly iatrogenic, but it certainly affects growth in young animals, but is usually quite clearly the cause of the altered growth. So these are the patients that we're treating for meningitis and things like that. So when you've got pituitary deficiency, so hyposomatotropism, these animals are perfectly formed, but they're just miniature. So they really cute. I've sort of been sent photos of this German Shepherd puppy that I put on my Instagram as the ad for this session. And he's so cute, but he's 2.5 years old and he weighs about 15 kilos and he's all fluffy, he's still got his puppy coat. Whereas hypothyroidism, they're not sort of perfectly formed dogs, they're weird looking dogs. So they've got short stumpy legs, a big head, but their torso is very normal. So they're disproportionately dwarfed. So they're short, but not necessarily small. So who gets pituitary dwarfism? What breeds?
German Shepherds.
Yeah. That's pretty much it. I know it's so rare. I've seen this population in my 10 years, quite a lot in specialist medicine. There are other breeds that are listed. So I think if you're sort of seeing a weird looking dog that's miniature, have a look at those rarer breeds, particularly given that sort of breeding can be international. These genetic pools can be international these days. What other clinical signs might there be other than their size?
I suspect there must be some sort of glucose dysregulation, but I actually don't know.
That's a really good point, actually. I haven't got that in my notes, but you would assume so, wouldn't you? So the main one is the coat change. So they never lose their puppy coat. Typically, that becomes clear around 3 to sort of 5 months of age. Their growth starts to become apparent, but it's not until 2 to 3 years of age where they develop clinical signs which are actually sort of detrimental to their quality of life. Do you know what the cause of those clinical signs are? There's a deficiency of something.
Is it the thyroid hormone?
Good, yeah, exactly. So they get insufficient TSH because of the hypoplasia of the pituitary. So they get hypothyroidism as well. And they start to develop symptoms of that quite sort of when they're adults. How do we treat it?
Yeah, it can be treated. Is there a synthetic growth hormone available?
Good. Yeah, there's a porcine. Is that how you say it? Porcine. Sorry. There's porcine growth hormone and there's human growth hormone, but it's not as well tolerated. So you can supplement growth hormone. What else would we need to supplement?
Possibly thyroid.
Good. Yeah, exactly. And then, we were talking about what causes hypersomatotropism in dogs. What was it?
Probably be pituitary tumor again, would it?
Well, that's one of them. But then we talked about the cool one
prolonged.
Yes. So there's sort of there's literature talking about using exogenous progesterone to stimulate mammary production of growth hormone in these dogs rather than supplementing it. Obviously, it's a cool trick. Yeah, extended exposure to progesterone comes with its own complications and you've got to make sure there's no uterine stump or anything in there. But it's an interesting option if growth hormone wasn't available for whatever reason. All right, we covered growth hormone in 25 minutes.
Hey, nice one.
Yay. Does anyone have any questions?
No, that was brilliant.
Yeah, it was awesome.
And to get last week's one, it's on the website, isn't it? vetsnorth.com.au.
Perfect. Yeah, that's a really nice plug, Jeff. Thanks.
That's perfect. Awesome. Well, enjoy your the rest of your day, Anna.
You too. Have fun, Josh. Enjoy your holiday. See you, Alex.
Bye.
Bye. See you, Jeff.
Bye.
Bye.
Bye, Josh. Bye, Anna. And thank
Bye.
you again.
Pleasure.